first. Thanks. Okay. Good morning, good afternoon, good evening, everyone, once again. So, we'd like to start. Um, my name is Faithful Lassie. I'm a general laparoscopic surgeon at the Redus Center for Digestive Health. And with me to anchor today's panel round is Dr. Baristis Udike, is a gastroenterologist and hepatologist at the Redus Center for Digestive Health. We are happy privileged to have with us today medical elder and senior distinguished speaker in the name of Dr. Salami Augustine. I'll be reading his bio briefly before we start. It's my pleasure to introduce Dr. Augustine Salami. He is a director of Interventional Endoscopy at Lee Health. He's a board-certified gastroenterologist with specialized expertise in advanced therapeutic endoscopy. He completed his medical degree at the University of Benin, Nigeria, followed by residency at the Henry Ford Hospital in Detroit, where he pursued fellowship in gastroenterology. He had additional advanced training in and fellowship training in interventional endoscopy at St. Luke's Hospital in Milwaukee.
We cannot hear anyone.
I think we lost Dr. Lassie there, and I have Dr. Salami's bio, so I can just complete this here. So Dr. Salami had his advanced training at St. Luke's Hospital in Milwaukee, and in his current role, he leads a cutting-edge interventional endoscopy program where they provide care, including with things like endoscopic ultrasound guided interventions, resection of complex GI lesions, procedures like POEM for Dr. Salami has really been critical in expanding advanced endoscopic care around where he's based in Florida. And he's also been very useful in trying to help centers in Nigeria develop advanced endoscopy as well. Over the last few years, he's been coming to support the program at Lasut. And so he's very passionate about advancing advanced endoscopy care in Nigeria and on the continent as a whole. So it's a pleasure to have him speak to us on interventional endoscopy and how we can expand this across the continent. So Dr. Salami, welcome and thank you for honoring our invitation to speak with us.
Thank you very much, everybody. It's a privilege to have this presentation. I apologize ahead of time. I just didn't know how quick things will go, so I might not get through everything. Hopefully, I can get a second time later in the future to present the rest of it. All right, so let's get started. Interventional endoscopy, just showing us what is possible with interventional endoscopy. So I'm going to move my screen here. All right, so the goals of this talk is to talk about what interventional endoscopy can offer our patients. A lot of us probably don't know what is available in interventional endoscopy, and then we need to know when interventional endoscopy can be supportive of surgery or other treatment that we offer, or it can be a definitive therapy for the patient. And interventional endoscopy is possible in Nigeria. We have the patients, we just don't know because we don't know what is available. As interventional endoscopists, we like to think of ourselves as at the center of the world, and we communicate with all these specialty. But really, the patient is the center of everything that we provide, and all of us work together to contribute care to the patient. And as we go through this talk, we'll talk about endoscopic ultrasound, interventional EUS, ERCP, balloon enteroscopy, enterostenting, third space endoscopy. If we have time, we'll touch on endobariatrics, endoscopic management of acid reflux, and endoscopic management of Barrett's esophagus. For those of us who've never seen the endoscopic ultrasound machine, that's the endoscopic ultrasound machine and the endoscope. It looks like a standard ultrasound machine. And the most common thing we do on EUS is to get tissue. And as the scope passes down the mouth through the esophagus, we can biopsy anything along the way, including lung masses, lymph nodes in the mediastinum. We can biopsy the pancreas, which is the major thing we biopsy. We can biopsy retroperitoneal lymph nodes. We can left kidney, left adrenal gland, splenic lesions, liver biopsy, including suspected metastatic lesions in the liver. We can also biopsy things next to the rectum, such as the perirectal lymph nodes, even the prostate, lesions next to the vagina, and the uterus can also be biopsied via EUS. And how does this happen? This is how the endoscopic ultrasound scope looks like. For those of us that have not seen the ultrasound scope, it's basically a scope with an ultrasound at the tip. We find our lesion, and our needle comes out from the scope and takes a sample of the lesion. And we can also advance the biopsy forceps through the needle during EUS to take a sample. And this technique is more sensitive, gathers more tissue, more diagnostic than a standard EUS. How does this happen? We use a special forceps called a Murray microforceps. So this is how it works. We find our
19 gauge
we find our lesion, put our 19 gauge needle, and our needle comes and take a sample of the lesion. So very effective in getting tissue via endoscopic ultrasound. Endoscopic ultrasound is also very useful in managing pancreatic necrosis. And usually when patient gets severe pancreatitis, which I know we have in Nigeria, sometimes these people end up getting surgery. But 4 weeks after the initial insult, usually we have a well-defined fluid collection. And here you see a CT image of a pancreatic fluid collection containing debris, which is not well visualized on CT scan. But the endoscopic ultrasound and MRI can see the necrotic debris. Here's an MRI image, a T2 weighted MRI. Here you can see the necrotic debris on MRI. It's not well visible on CT scan, but on MRI you can see it. And the old way we manage in the United States and elsewhere around the world, you puncture the fluid collection with a needle, you advance a guide wire, you pass a balloon to dilate your tract between the stomach and the fluid collection, and you place stents. This way you drain the infected fluid collection into the stomach. Now we use a special stent called a lumen-opposing metal stent. And this is how it looks like when it's not deployed. During deployment, you deploy the internal flange, and when it's fully deployed, it looks like this. And this is a cartoon showing the stomach, showing the necrotic fluid collection. This necrotic fluid collection can be infected. It can cause sepsis and put the patient in the ICU. It can obstruct the stomach. So it needs to be drained. And the best way, the first line treatment is endoscopic drainage using the stent. And this is the stent in position. In the past, as I mentioned before, this is the walled off necrotic collection. I'll let the video play. Here, the collection is punctured with a 19 gauge needle right there. And then we're going to pass a guide wire down into the cavity. This is done under EUS and under fluoroscopy. We'll pass a guide wire, and then we're going to put a balloon to dilate it. And then eventually we're going to deploy a stent. In this case, we use a metal stent. However, now we can just do a axial stent. I'll let the master, Ken Ben-Muller, who invented the stent, talk on how to deploy this. For those of you who've never seen this before, this is a game changer on endoscopic ultrasound.
And I don't know if you can see that on the room view camera, but we're going to start by unlocking the sheath at the top of our screen. There it is.
So right here is the EUS scope. Is the lamps about to go into the cavity.
Step on the pedal. We're inside of the cyst now. We're going to advance the sheath all the way to its maximum. We're going to now lock the sheath. We're going to take off the safety pin. We're now going to unlock the gray hub here, this releases the distal flange. So we just pull back until we hear a click, and it will automatically stop after the distal flange deploys. We're going to unlock the sheath now, and we're going to pull back the sheath, and we're going to snug the distal flange up against the wall of the cyst. We're now going to relock the sheath, and as I pull away from the wall,
So
at
right
this
here,
point in
the
advance,
stent is being deployed, and you're going to see all the infection coming into the stomach.
push the proximal flange out. You can see there's already ample fluid gushing out.
All right, so this is my personal patient. This guy had a severe necrosis extending down the left upper quadrant, left paracolic gutter, all the way into the pelvis. So over several sessions, I've completely cleaned out that cavity. The patient also had a percutaneous drain that you can see right there on the screen. And I'm going all the way with a scope behind the stomach, all the way to the pelvic area. It's completely cleaned out. This guy did very well, eventually, yeah. But he was sick, septic in the ICU. And if he had had surgery, it would have been pretty extensive surgery. And this is the CT scan image of that same patient. This is the stomach up here. This is a coronal view of the patient. This is my stent right here in position. And you can see my pigtail stent. Here's our external percutaneous drain and extending all the way into the pelvis. So that image showed the scope going all the way down here from the stomach to manage this condition. EOS can also be used for staging to guide treatment of esophageal, gastric, rectal cancers, ampullary, gallbladder cancer, biliary cancers, and EOS staging of neuroendocrine tumors. This allows us to tell if we can go straight to surgery or if our patient needs adjuvant treatment such as chemo, radiation before surgery, or if patient can be a candidate for endoscopic treatment. In case rendezvous. And in this situation, this is the EUS scope. We're not able to get access into the bile duct. The EUS scope advances here, punctures the bile duct, advance my guide wire down into the duodenum, loop my guide wire multiple times. And now I'm going to pass either my 0.025 or 0.035 angle tip guide wire. This is done under fluoro and ultrasound. Once my guide wire is in place, I'm going to remove my EUS scope, and then I'm going to remove my EUS scope by leaving the guide wire in place. Then I advance my ERCP scope to all the way down alongside the guide wire to the major papilla. Once I'm here, I have two options. I can cannulate alongside the wire, or I can pull the wire in and cannulate. This is what interventional endoscopy can do. So you can always have access to the bile duct. In cases like in pancreatic cancer, where the tumor has prevented entrance into the bile duct, we can perform an EUS-guided choledochoduodenostomy. That means advance the stent directly from the duodenum bulb into the bile duct. Here we have a specialized lumen-opposing stent. We've punctured the bile duct. We're going to deploy the internal flange. This is a very specialized procedure. It's a high-risk procedure. The internal flange has been deployed here. This is the ultrasound image. Here we're gonna, once the internal flange has been deployed, we're gonna pull the stent right against the duodenal wall. This patient has chronic biliary obstruction. So now we're gonna deploy the stent, and you will see the clear bile indicating a chronic obstruction once the stent has been deployed. So right there, you can see the clear bile. EUS is also important in managing acute cholecystitis. For the surgeons in the group, sometimes the patient is not a good surgical candidate for whatever reason, and the American Gastroenterology Association recommend if there's concern for gallbladder perforation, you go with percutaneous gallbladder drainage done by interventional radiology. If there's no perforation, you have two options. You can perform an ERCP and place a stent through the papilla into the gallbladder, or you can perform EUS-guided cholecystoduodenostomy using the same lumen-opposing stent. I'm not going to dwell too much on this because I'll talk about them individually. This is an internal study that showed that EUS-guided gallbladder drainage has similar technical success and a higher clinical success than percutaneous gallbladder drainage. So the ESGE, which is the European Society of Gastrointestinal Endoscopy recommend EUS-guided gallbladder drainage is favored over percutaneous drainage, where both techniques are available, owing to the lower rate of complications and the need for reintervention. The American Society of Gastrointestinal Endoscopy recommend EUS-guided drainage as an alternative where the expertise is available. This is a cartoon showing how it's done. Here's a gallbladder, enlarged, multiple stones. The axios goes in, no guide wire, no needle, no fluoro. Goes in and you deploy your stent. And this is right on the right side is a personal case. Here's the gallbladder, multiple stones in the gallbladder. This patient is a very poor surgical candidate. So this is me. I've advanced my axios into the gallbladder. I'm going to deploy the internal flange, and I'll show you what we did here. So here you have to be very precise. So the internal flange has been deployed, and this is me deploying the external flange in the duodenal bulb. Again, this patient had hydrops. So the stent has been deployed. So once the stent has been deployed, now I'm going to go back a few days later to remove the stones. So these are the stones in that gallbladder. I'm going to use a combination of a rat tooth forceps and the rod net to remove the stent. So this is me. I'm removing the stones, and it didn't take long at all. Once I remove the stones that's occluding the stent, I'm able to go in with a rod net, and this is multiple stones in this patient that I removed, at least 10 stones. In some patients that are young, maybe they are cirrhotic patients, not a candidate for EUS-guided drainage, or the gallbladder is not distended, we perform EUS transpapillary gallbladder drainage. You perform an ERCP, advance your guide wire into the gallbladder, you balloon dilate the cystic duct, and put a double pigtail stent. In this study, published in World Gastrointestinal Endoscopy 2021, 1,300 patients, 82% technical success. But look at the clinical success, 94%. This is my personal patient. This patient here had a subtotal cholecystectomy because it was very difficult, so they couldn't take out the whole gallbladder. But the cystic duct, it was still obstructed. So the patient kept having liver abscesses next to the cystic duct every 2 to 3 months, getting percutaneous drain. So they called me. So here, the gallbladder was too small for me to perform EUS-guided drain. So here, you can see me here. I'm trying to force my way through that cystic duct stone. Eventually, I'm able to get my wire across that stone. I'm going to coil that wire into that gallbladder remnant, and I'm going to place my stent. So eventually, I was able to establish patency of that cystic duct. And the patient, since then, it's been about a year now. The patient has not had any episode of liver abscesses. Sometimes, everything else has failed. You can't get access with the transpapillary. You can't get a stent into the bile duct. So we perform a hepatical gastrostomy. Here we puncture the bile duct from the stomach, segment 2, 3 of the liver. We advance the guide wire down. We advance either a cystotome or a 4mm hurricane balloon. We dilate the tract between the stomach and the liver, and then we advance the stent. This is a hepatical gastrostomy. This procedure is a very high-risk procedure, high risk for bile leak. So you have to be an expert to perform this procedure, and that to be a last resort. I've performed just about 10 of these procedures. In patients with gastric outlet obstruction, malignant gastric outlet obstruction, the pancreatic tumor, duodenal cancer, and pulmonary cancer has completely blocked the duodenum. Food cannot go through. We can perform EUS-guided gastrojejunostomy, placing a stent from the greater curvature of the stomach into the proximal portion of the jejunum. So the food is going to bypass this way and go down this way. So in this situation, we advance a 7 French nasobiliary drain into the jejunum beyond the obstruction. We fill it up with methylene blue and saline, and the stent is going to go in again. Same lumen opposing stent into that jejunum. We deploy it. The internal flange has been deployed. The external flange we deploy in the stomach. In this situation, we've advanced the guide wire. After the stent has been deployed into the jejunum, we're going to dilate it. That way, the patient can start eating the next morning instead of waiting for the stent to expand. Here, we're dilating the stent under fluoroscopy. And once the stent is dilated, you can see the jejunum on the other side. So this is similar to a surgical gastrojejunostomy. In this patient here, I could not even get my guide wire to go through. So I punctured the small intestine with a 19 gauge needle, and I'm filling it up with contrast. And I'm going to perform a EUS guided freehand axios. Here, the contrast is draining backwards to the obstruction. No contrast is flowing into the stomach. Once my stent has been deployed, I'm going to put a balloon and I will dilate this patient. This was done as an outpatient, 45 minutes, and patient's going home and eating. And mind you, the stomach is full of food. Yeah. EUS can also be used for certain things, and I'm going to go over them very quickly. Sometimes it's difficult to make a diagnosis. EUS guided contrast elastography it's able to help you to see the tumor. We inject 4.8 milligrams of sulfur hexachloride, and it's able to differentiate between a malignant tumor and an inflammatory tumor. Here's a EUS image. The pancreatic tumor here is hypovascular, and this reduces the number of needle passes by 30 to 40% and helps you to differentiate between malignant and inflammatory tumor, especially if the biopsies are non-diagnostic. Sometimes this gives you more information. It adds a vascular mapping beyond just grayscale EUS. EUS can also perform elastography similar to your fibroscan, able to differentiate between malignant and benign tumors. This also helps you if you don't have the contrast enhanced elastography, which is pretty rare. This one here, it tells you the hard, the malignant lesions are hard. Here you have your EUS elastography showing that the tumor here is hard, is blue, and right here red is soft. And it's the same thing. You perform it in real time. Once you put on your elastography and then you freeze, and then you can see where your target for FNA is. EUS can also help to manage intractable pain from pancreatic cancer patients. We inject 100% absolute alcohol around the celiac artery, and as well as bupivacaine. This improves pain in pancreatic cancer patients by 70 to 80% in a difficult situation. It helps us to reduce the amount of oral pain medication that these patients take. EUS can also be used for liver biopsy in patients with abnormal liver enzymes. You can access the left liver and the right liver. And I'll talk more about it as we go along. And somebody might ask, why do you perform EUS guided liver biopsy? Why don't you just do a percutaneous biopsy? Well, if you have a patient that's going for an endoscopy for a different reason, abdominal pain, varicose screening, GORD, you're evaluating the bile duct, you can perform EUS guided liver biopsy instead of doing two different procedures. Some patients also just don't like being awake while a needle is being passed into their liver. In this study from Gastroentertional Endoscopy 2016, EUS liver biopsy provided similar diagnostic sample to percutaneous and transjugular liver biopsy. How do you measure the adequacy of a sample? Total sample length and complete Porter triad. The AASLD, the American Association for the Study of Liver Disease, recommend at least 2 centimeters for a sample length of liver biopsy, and Porter triads, a complete Porter triad in that sample to be about 11 or more. EUS guided liver biopsy can provide that length and provide an average of 20 complete Porter triads. This is an example of a EUS guided liver biopsy, just as effective as a percutaneous biopsy. In this study out of in the Endoscopy International 2016, EUS guided liver biopsy provided significantly more total sample length and complete Porter triads when compared to percutaneous liver biopsy and transjugular liver biopsy. Also, we know that the higher your Porter pressure, the more severe your liver disease is. We can perform endoscopic ultrasound guided Porter pressure measurement. In this original article published in 2021, EUS guided Porter pressure measurement provided similar measurements to a transjugular liver measurement. How do you do this? if you ask, we provide a custom-made 25-gauge needle, custom-made pressure measurement device placed at the level of the heart. We identify the left hepatic vein, giving you the characteristic four-phase waveform. We'll puncture the liver, and you can go through the vein. Once you are in the middle of the vein, you're going to you flush it with heparinized saline, you get an average of 3 measurements. And then you're going to find the left portal vein, characteristic monophasic waveform. Again, you puncture the left portal vein. You can go right through it, and then you pull back until your needle is right in the middle of the left portal vein. You're going to again flush with heparinized saline, and you get your 3 measurements, and then you take the difference. And then you can get your portal gradient. This is a direct measurement, not a wedge pressure. In this study, 159 patients, it showed that EUS PPG measurements were consistent with the histological grade of fibrosis. And EUS measurement were able to rule out some false positive from transient elastography done in these patients. EUS can also manage gastric viruses. We know that gastric viruses are very high risk. 65% are going to bleed in a 2-year period and are very severe, require multiple transfusions, and associated with high degree of mortality. This is the Sarin classification of gastric viruses. Gastric viruses along the lesser curvature, gastric viruses along the greater curvature, and isolated gastric viruses in the fundus. The 2 most serious one here that cause most of the bleeding are gastroesophageal viruses type 2 and isolated gastric viruses, mostly in the fundus. And I'll outline them right there. These 2 cause most of the bleeding. How do we treat it? Band ligation for GOV1 and band ligation sometimes for GOV2 and cyanoacrylic glue. That's the glue, the CA there, injection. And that's where EUS will come into play. What do we do exactly? This meta-analysis, 7 studies show that when you inject glue, it lowers all-cause mortality and it reduces the rebleeding rate. The video is just showing how when the glue comes in contact with the solution, it solidifies. So that is what we use to treat this. Why EUS? Why not just puncture the virus directly and inject? Well, EUS allows you to be able to target the feeding vessel so that you don't have to inject a lot of glue. And it allows you to be able to detect your viruses 6 times more than just looking at it with white light endoscopy. And you can target the culprit gastric viruses, and you can see when you've treated enough because the Doppler imaging, the Doppler pattern will much reduce. And with EUS, we can deploy coils, COIL, as well as glue. So this is a life-saving procedure that I've done multiple times when there are no other options. This is ERCP. We know we've seen ERCP. A lot of us are familiar with this. ERCP indications for bile duct stones, bile duct strictures, benign and malignant, bile leak, sphincter of Oddi dysfunction, ampullary lesions. We don't perform diagnostic ERCP. We only perform therapeutic ERCP, which means we've identified the problem and we're going in there to treat the problem. No diagnosis. All right, so this is just a picture of an ERCP suit. Here we can perform fluoroscopic guided biopsies of lesions within the bile duct. And we can also do biopsies from the bile duct using a cholangioscope. This is just showing the different types of cholangioscope are available from Boston Scientific, Steris Endoscopy, and from Medtronic. Here, we have a large stone that we're not able to extract. Okay, so this video doesn't play, but basically we advance our SPY scope and we can use electrohydraulic lithotripsy to break down the stone. The most important thing though is that with EUS, one of the most difficult cancers to diagnose is bile duct cancer or cholangiocarcinoma. So difficult that, especially in the hilum, that is one of the only cancers where you can begin treatment without actually having a tissue sample. Here is a normal bile duct, and here is an abnormal bile duct. We can take a biopsy. Let me show you how this. The cholangioscopy performed via ERCP helps us to improve diagnostic accuracy. Here we advance the cholangioscope inside the bile duct. We can advance the biopsy and take a biopsy. We can advance the cholangioscope and take a biopsy from it. All right, so and here I basically just showing you the different patterns. We can see abnormal blood vessels. This is direct images taken from cholangioscope. We can see polypoid masses. Sometimes they have the papillary projections or an infiltrative pattern. We can also, for an interventional endoscopy, we perform complex ERCPs, B-ROT1, people that have in altered anatomy, B-ROT1, B-ROT2, post-Whipple, hepatic cholangiectomy, post-bile duct injury, or even patients that have had Roux-en-Y, we can perform an ERCP. We can also perform balloon-assisted enteroscopy deep into the jejunum and the ileum. Various indications, mostly for GI bleed, chronic diarrhea, foreign body retrieval. And the two types of technique we have is a single balloon enteroscopy that has one balloon and the double balloon enteroscopy. These things are available via interventional endoscopy. And here we can perform enterostenting for esophageal cancer. If we have a tumor completely obstructing or partially obstructing the esophagus, patient is not able to eat, we go in and we place a stent. You can deploy the stent under fluoroscopic guidance, or you can deploy it under direct endoscopic visualization. The video is playing and showing the stent being carefully deployed, and then the patient is able to eat. We can also deploy a stent in the colon. This is the rectosigmoid, or you can deploy it in the duodenum for gastric outlet obstruction, where the expertise is not available for EUS guided gastrojejunostomy. How do we do this? We advance the guide wire across the obstruction, and we deploy a stent across the obstruction. Here, the stent is being deployed across the obstruction. This one is relatively straightforward procedure. What we also do, we resect endoscopic. We resect polyps in the stomach, esophagus, even early esophageal cancer. That means superficial cancer. This can be the cure for it. Gastric cancer, cancers in the rectum, large polyps. No matter how big the polyp is, 8 centimeter, 10 centimeter polyp, as long as it's not cancer, it can be removed endoscopically. How do you perform EMR? Different techniques, endoscopic band EMR. Here we identify our lesion. We identify a lesion. So here we have injected, and then you perform a band, just like you do with esophageal varices, and then you use a snare to resect it. So the conventional way that most of us are used to is lift and cut. We inject our polyp to create a submucosal cushion between the polyp and the muscle, and then we get a snare placed over the polyp, and then we resect. And you can do this over and over again if you've got a giant polyp, as long as you make sure you get all the margins of the polyp. My favorite, which I've used to use now 90% of my cases, is underwater endoscopic mucosal resection. No injection, no bands. You just fill your colon or your GI tract with water, and then you can resect. You can perform endoscopic full thickness resection. These are for early cancers, less than 2 centimeters. You resect the lesion along with the submucosa and the muscle. And here's the technique. You grab, you pull into the scalp, you deploy your clamp, and then you cut above. And this is a patient that I did 2 weeks ago. This patient has got a mucinous ampullary tumor. This is the appendiceal orifice. My device is in place. I've identified my lesion. I'm suctioning in, and I'm going to cut the lesion out. Once I cut the lesion, I remove it and I go back in. I take a look. Here's your appendix orifice here, and here's your clip in place. This is the peritoneum and the serosa. So this is a full thickness resection. Very effective, and this is an outpatient procedure, and saves the patient a right hemicolectomy. Let's talk a little bit about thought space endoscopy. I'm moving fast, but I'm trying to get through as much of this case just to introduce you to this. At a later date, if we want to focus more on any topic, we can talk about it. What is the indication for endoscopic submucosal dissection? Early cancers. The difference between ESD and EMR is that you can get en bloc resection. You want to make sure that there's no submucosal invasion, no lymphovascular invasion. You can do this via CT scan and endoscopic ultrasound. You perform endoscopic ultrasound to make sure there's no invasion, and then you can resect. What is the technique? Basically, you identify your lesion, you mark around it, you inject, and then you dissect underneath it, and then you resect. So here is the technique here. This is my lesion. I'm going to mark around the lesion. I've done my circumferential marking. I'm going to inject to create a submucosal bleb. And then I'm going to now create a circumferential mucosal incision using my endoscopic knives. There are very many of them. You pick your choice, whichever one you were trained with and which one you're comfortable with. I make a circumferential incision, and then we can resect. So now this can allow you to cure cancer, early cancer. You don't need surgery. In the esophagus, in the stomach, in the colon, even in the right colon. And once your sample is out, you can evaluate it for negative margins. Okay, so another thing that we perform is POEM. This is the ABCD of POEM. The most common POEM, where POEM originated from, is E-POEM performed for achalasia, or just POEM. C-POEM is very rare, performed for cricopharyngeal hyperplasia, something that goes unrecognized. D-POEM is performed for diverticular POEM in the esophagus, not Zenkas. Anything that's not Zenkas, anywhere else in the esophagus, you perform a diverticular POEM. A Z-POEM we perform for Zenkas diverticulum, and the G-POEM we perform for gastroparesis. Achalasia is our most common diagnosis. Most of you know achalasia. This does not relax, and this does not contract. Very rare, common in presents in 1 in 100,000. Symptoms are difficulty swallowing, regurgitation, weight loss, choking, heartburn, chest pain. These patients are miserable. How do we diagnose this? A barium esophagram. You inject contrast, and the contrast pool in a dilated esophagus and have a very thin layer going in. And we call this the characteristic bed-beak appearance on the barium esophagram. The gold standard, however, is a motility study where we pass a probe down the nostril in through the GE junction, and you have the patient swallow 10 sips of water, and then you get your motility graph. This is not a motility study, but this is basically the 3 types of achalasia compared to the normal. In the normal topography, once you swallow, the upper esophageal sphincter opens, the food goes down, the lower esophageal sphincter is the lower esophageal sphincter is relaxed. Here, type 1 achalasia, there's no contractions at all. In type 2, the pressure equalizes throughout the esophagus, creating a panosophageal pressurization. In type 3, there's spasm in the distal esophagus. If you don't have a motility probe, you can perform the endoflip, the endoluminal functional probe, and this one is better tolerated by the patient because the patient is under anesthesia. I'm just going to put on my light. All right, so while the patient is asleep, we advance our endoflip probe down the esophagus. You've already done a pre-operative endoscopy. You position your endoscope right across the GE junction. And here you can measure the distensibility and the diameter. So this is similar to the motility study, and you can get real-time images and give you useful information to manage the patient. Achalasia treatment can be pneumatic dilation, which is available in Nigeria. You can perform Botox injection for patients who are poor surgical candidates. You inject Botox in the forequadrant at the GE junction. This is temporary, it doesn't last. You can perform a Hela myotomy, which is available in Nigeria. But we'll talk about the poem here, first performed in Venezuela, but made mainstream by the professor from Japan. He performed the first case in 2006, published the article in GIE in 2010. Right now, laparoscopic Hela, pneumatic dilation, and poem are effective therapeutic modality for achalasia. Your decision, your option should be based on local expertise, patient preference, and obviously the type of achalasia. And the next, for type 3 achalasia, poem is preferred. Why? Because of this spastic segment. It's a long segment of spasm. So even if you cut the GE junction, you still got the spastic segment. You got to cut it. If you're performing a Hela myotomy, if you're a surgeon, you're not able to get all the way high up into the esophagus to cut as much muscle as possible. That's why we prefer poem for type 3 achalasia. And how does poem work? As we talked about before, the lower esophageal sphincter does not relax, and you lose contraction. So these are the two. This is a normal esophagus. This is a disordered esophagus. So I'll just quickly show you the cartoon. Here we've created our tunnel, and we advance the scope all the way into the gastric, into the stomach, and then we'll cut the muscle. You cut the muscle, cut along the sphincter into the stomach. Once we've cut the muscle, we're going to come out and close with clips. That's the standard of care, but I'll show you a different method that I used in the past. So this is my patient, very tight sphincter. Here I'm going to inject about 10 centimeters from the GE junction. I'll create a submucosal bleb. If you notice, my incision is going to be a horizontal incision because I plan to suture this opening. I don't plan to clip. I'm going to start performing my submucosal. I'm going to enter the submucosa. I'm using my my knife here. I'm inside my tunnel. Here's the muscle, and here's my submucosa. Following this section all the way to the cardia, I'm performing my retroflexion. I can see my mucosal bleb right there. I'm going to come back into my tunnel, and I'm going to start my myotomy. I'm back into my tunnel. I'm going to start my myotomy. I'm going to start cutting the muscle. Initially, I start with a selective myotomy. Only I'm cutting the circular muscles until I see my longitudinal muscle. Then I stop cutting, and then as I'm cutting down, I'll maintain that plane until I get to here. You can see my longitudinal muscles. Once I get to the G junction, I perform a full thickness cut all the way into the mediastinum and across the cardia into the peritoneum. And this is an outpatient procedure. Patient's going to go home that same day. That's how effective. And this whole thing takes less than 1 hour. So once I'm done cutting, I'm happy that I've cut enough muscle. I'm going to come out and load my suturing device to close. Here's my suturing device. I'm just going to close my opening. And that's it for that procedure. Patient goes home. This is just the long-term outcome. Poem is very effective. 94% effectiveness in 1 year, 88.2 in 5 years. Patients will feel the difference almost immediately after they wake up. We'll talk briefly about gastroparesis, which is inability of the stomach to empty adequately. And gastroparesis, ideally, your stomach should be emptying 90% of the food you eat in 4 hours or less. In gastroparesis, the stomach doesn't empty that quickly. Less than 90% of the food, 60, 70%, and this patient feel the symptoms: nausea, vomiting, bloating, abdominal pain. The most common cause of the most common cause, at least in Nigeria, diabetes, post-surgical cause, vagotomy, oesophageectomy, hernia repair. This is how you check your symptoms using the gastroparesis index score. The higher the score, the more severe is the symptom. How do we treat it? Dietary modification, low fiber diet, medications, prokinetics, antiemetics, Botox injections, stenting, gastric electrical stimulation. And obviously what we do is GPOEM. GPOEM was first performed in 2013 by Moin Kashab out of Johns Hopkins Hospital. And this is, I'm going to let this video play simultaneously. On the right is an actual patient of mine. Basically, we want to cut this muscle here. We inject a bleb, a similar technique to a POEM. We just perform it in the stomach. So same thing, we inject, we make a bleb. I'm going to enter my tunnel and then go all the way up here. If you're looking on the right-hand side, it's my tunnel. I'm going to advance my scope until I see my pyloric ring, which appears as a characteristic half-moon shape muscle, and then we cut that muscle and come out and close our opening. In the cartoon on the left, you can see the dissection ongoing. Once we identify our pyloric ring, we have an IT knife here, an insulated tip knife, hook, side-by-side images of the pyloric ring in the cartoon and in real life during my procedure. And we cut. And that's it. Again, this takes 45 minutes to an hour. Clinical success is defined by GCSI score decrease less than 1 or 25% decrease in at least 2 of the subscales. This procedure is not very effective, 61%, 66%, but it's a very good option in a very difficult diagnosis. Zenker's diverticulum, basically an outpouching in the neck, where now in the Zenker's you have 2 openings. One is this blind pouch, and this is the esophageal lumen. Basically, to treat it with the Z-point, you expose the muscle, you cut the muscle, this muscle has been cut, and then you close. Again, this is a patient of mine. That video is not going to play, eh? Okay. Basically, you cut the muscle, and then you expose it, and then you close your opening. It's very effective. I love seeing the Zinker's patient in the office because I know that I can do something. It's very easy, 30 minutes, and it's extremely effective. It's life-changing because this patient sometimes end up in the ICU with aspiration. So every time I see a Zinker's patient on my office schedule, I'm very happy because I know, oh, this is going to be straightforward. And then for cricopharyngeal myotomy, this one is a little bit very difficult to diagnose. You have to have a high index of suspicion. These patients will have symptoms of difficulty swallowing, choking, and coughing, and regurgitation of food after swallowing. Basically, there's a hyperplastic muscle at the upper esophageal sphincter, and this is how it looks, very tight. This is after savory dilation. This is the upper esophageal sphincter. How do you diagnose this? Through a barium or aspiration study, and this is the classic appearance on the aspiration study. And right here, you can see the cricopharyngeal bar, and savory dilation, you can start with that. If it's effective, then the definitive management is a C-point. And same technique, identify your muscle, inject, make your mucosal incision, expose the muscle, cut the cricopharyngeal muscle all the way to the buccopharyngeal fascia, and then you close the multiple hemoclips. This video plays. This is my patient. I've made my incision into the I'm just going down the esophagus. I have on an ST hood from Fuji. I made my incision. I'm going to go into my tunnel. I've already cut my muscle here, so you will just see the end product. Again, this is a very high risk procedure because if your closure is not perfect, you have a leak into the neck and you get neck abscesses. Here, I've cut my muscle on either side, and here's your fascia, so the fascia around the neck. And this is an epiphenic diverticulum. Here you got a big diverticulum in the distal esophagus, so food goes into the diverticulum, some goes down here. The technique is to cut the septum between both the diverticulum and the esophageal lumen. This is a patient. I'm going to so I'm just going to get that video. So this is a patient with a giant esophageal diverticulum. My scope is in the diverticulum. I've cleaned it of all the food. This is the lumen of the esophagus. It's not able to eat. So you're going to see so right here, you're going to see what I'm going to do. I made my tunnel, this time around, I made my tunnel close to the diverticulum so I don't get lost in the esophagus. So you can see the muscularized profile of the esophagus. I'm going to enter into my tunnel. Again, I'm using an ST hood from Fuji, which allows me to slip into tight spaces. Here's the submucosal, this is the diverticulum. Underneath the surface, this is the muscle, and this is the esophageal wall. So I'm going to cut that muscle. And again, this is an outpatient procedure, very effective for these patients. And based on the data, 92% effectiveness, and patients are very happy. And then I can also resect submucosal tumors from the muscularis proper, GIST, leiomyoma, schwannoma, or the fibrosarcoma. Technique is the same. Create my submucosal bleb, create my tunnel, get to my lesion, cut it, and I retrieve it out of the esophagus. This is a 3 centimeter proximal esophageal GIST that's lighting up on the PET scan. This is the lesion after it has been resected. This was a difficult case. It took about 5 hours to resect. And I'll show you, that's the lesion after it had been resected. This was not an outpatient procedure. Patient stayed in the hospital. This is me in my tunnel during the procedure. I've dissected above the lesion, I've dissected around the lesion, and I'm going to remove that lesion. Basically, it saves the patient from getting an oesophageectomy. And this is a gastric GIST that has bled, kept the patient in the hospital. And this is me after I've resected the lesion. I suture my defect. And 6 months later, you can see the scar tissue from the resection, completely healed. Lesion is completely out. All right, so I'm going to stop there because I know it's been a lot of information. I have some more, but I think we ran out of time. If you have any questions, we can. If you have any questions for now, you can ask me. So we just talked about a few topics of things that we can do with endoscopy. Things that you might not know. Some of you probably might not know that exist, but these are things that I do every day. And some patients in Nigeria have it. I don't know what happens to them, but if these things are available, we can do it. Thank you.
Thank you so much.
If you have any specific questions, I have the endobariatrics, but we'll keep that for another day. And so that's a different topic. It's not critical. That's for people that want to lose weight.
Hello, Dr. Salami, can you hear us?
Yes, I can hear you. I can hear you.
Okay, thank you so much for that master piece and a very excellent presentation, quite engaging and quite informative as well. Thank you so much. I'm going to transfer the rest of the moderation of the discussions to the baristas for the Q&A session. People should please kindly send their questions and comments on the chat room. Thank you.
Yeah, thank you, Dr. And
uh, uh, I can't hear you, Baristus. Maybe somebody that can hear him can.
okay, can you hear me now?
Yes, I can hear you now.
Okay, yeah. I was just thanking you for that wonderful presentation you just delivered. There are some questions, but we're still waiting for more questions to come up. But I want to start with this question. As we were presenting, we were just looking at where the journey so far, getting to where you are now. I want to start with that. For somebody that is just doing open endoscopy, colonoscopy, and intend to advance into these complex procedures, starting from the basic. How many open endoscopies do you think one or colonoscopy one should have done to venture into advanced procedures?
No, so you can go because in the United States, that's where I am, they have a year of advanced training, which you can go directly from your GI fellowship. So once you've had that basic training in endoscopy, EGD, and colonoscopy, you're good to go. Once you are stable, you're good to go. As long as you can have somebody to train you. Here we have training programs where we can.
So for us in Nigeria, many other parts of Africa, we don't have organized training for advanced program.
Yeah.
So we do like apprenticeship now, follow, and then like you are doing procedures. Where there is no advanced procedures, there is an organized advanced procedure. When do you think that one is really comfortable to start learning how to do advanced? That's in our own environment where there is no organized advanced program.
Yeah, it will take a while for us to have advanced training. It will take a while. I'm looking at probably another 5 to 10 years before at least we have 1 or 2 hospitals that are training. It's the same thing as any training that you've had before in your life. You need to have somebody that's doing it and you're following them, you're doing the procedures with them. It's the same thing. All this training is done in 1 year. And the 1 year of training is not really for you to learn every advanced procedure in the world. It's just to give you that confidence that you can give you the basic training. And then as you progress in life, you can do these cases and anything in life. So the more you do, the better you get. I'm not better than anybody, but I just happen to have the opportunity to be in the situation where I am. I got the training, I got exposed, and that's how I'm doing these cases. In fact, I don't think I'm a good. When I was in training, I was not the best endoscopist, but I did the training, and the training gives you a lot of confidence. I think we'll get there. It might be another 5 to 10 years before we get these procedures available. Again, it's not going to be like in the United States where it's available almost everywhere. It's going to be in the big centers because these procedures are also very high risk. So you don't want to do it in a regular setting.
Thank you. So I want to throw more light on how to deploy axons because that was where part of where you started when you were early, when you were starting your presentation. So can you throw more light on how to deploy axons, just a brief step by step?
Yes, I'm going to answer that question with the question that Dr. Ulasi asked in the chat. So the question is, what is the difference between stent, a duodenal stent, and EUS GJ? So if you deploy a duodenal stent, it's an uncovered stent. It's designed for the tumor to grow into the stent. Usually after about 3 to 6 months, if the patient is still alive, that stent is going to get blocked. So what we do is that we go in and we place another stent inside of it to open it up. But the EUS GJ does not get blocked. You deploy the stent, the patient is eating the next day, and it stays open even for up to 2 years. Yeah, so that's the difference. It's very effective. Patient can eat normal food as compared to the duodenal stent where they have to eat a stent diet and it gets blocked. So the axial stent is designed to be deployed under EUS only. It's very easy to deploy. So no guide wire, no needle. It's electrocautery enhanced. The tip of it has electrocautery. You identify your target, put your stent right against it, press the pedal, and the stent goes in like knife going through butter. Goes in, once it's in that cavity, because that's the most difficult part. You got to get it into your target. You can't miss. Once it's in, then you deploy. Deploy one flange is designed so you don't make mistake. You deploy one flange, you pull, and it locks by itself. So you cannot deploy a part of the stent until you're ready. So it requires training, but once it's available, it saves patients from big surgery.
Thank you. There's another question Dr. Last asked. What are the key considerations to make prior to interventional endoscopy after mortal anatomy? For instance, is gastrojet a contraindication for ERCP?
No. So I'm trying to say gastrojejunostomy. No, I do a lot of ERCP in alternate anatomy. In fact, last week I had 4 cases back to back. This patient has bile duct injury, and another one had bile duct cancer too. So they had a gastrojejunostomy and a hepaticojejunostomy. So I can't guarantee that I can get there, because if the afferent loop or the pancreatobiliary limb is very long, or the rule limb is very long, I may struggle to get there. But most of the time I can get there. Sometimes I've had patients that the surgeon from a big teaching hospital will tell them nobody's getting there. Let me take a look. I go down, and we don't use a regular ERCP scope. We use a colonoscope or an enteroscope, because an ERCP scope has the camera on the side. You can't move through these bending loops with an ERCP scope. So we use a colonoscope and a PCF scope. Yeah. So interventional endoscopy is so broad. If there's a specific topic that we can talk about it in the future. ERCP in alternate anatomy is a different topic on its own. And I still have the EDGE procedure. We didn't talk about that. That's in gastric bypass patients. I don't know if we have a lot of gastric bypass patients in Nigeria, but if you've had gastric bypass, now we can't get to the papilla because you've been bypassed. We perform the EUS guided, EUS directed transgastric ERCP, where I place a stent between the gastric pouch and the excluded stomach, and then pass through it to get there. And we can perform this procedure in 40 minutes. We go in with a gastroscope, identify the gastric pouch, EUS scope, puncture the excluded stomach, inflate it with water, deploy your axios, EGD, fix the stent, dilate it, ERCP, go through the stent, and perform your ERCP. So ERCP in alternate anatomy is possible. Even in Nigeria, you just if you have a PCF scope, you're good to go. Yeah.
Thank you. So it's possible, but very complex. It's very possible in the experience. All right, thank you. Why are both banding and snare concomitantly necessary in EMR, as shown in one of your videos?
So there are different techniques for EMR. For Barrett's esophagus, which is a risk factor for intramucosal adenocarcinoma, sometimes when you're examining your Barrett's, you're using high definition white light, narrowband imaging. Now you see a small node, NODE. You can perform band EMR, no injection. You come out, you load your band like you're performing banding of varices. You go in. It's easier. You just so what you do is that you mark around your target, you suction it into the band, deploy, and then you cut. There are 2 different techniques for EMR. The band EMR is mostly used in the esophagus, where it's easier. There's no need to inject or lift, and it's easier to resect early cancer, T1A, intramucosal adenocarcinoma. Yes, there are less indications. I see the questions. There are less indications for lower GI intervention, but we still intervene in the lower GI, colonic stents, resection of large colon polyps. I resected, I have a guy on my schedule today. I resected an 8 centimeter polyp. So I'm just going in to check to make sure it's all taken care of.
Thank you. So another question, in patient with stricture that you are dilating, and with patient who came with stricture, multiple dilation and restricture, what do you do to reduce the frequency of stricture in such patients?
So if you dilated a patient multiple times, and it's not responding, that is considered considered the refractory esophageal stricture, especially if, I don't know what stricture you're talking about, but if in the esophagus, then that's a refractory esophageal stricture. You can use a stent. That is not an official indication for a benign stricture. It's used for it's a malignant stricture, but you can use a stent. Number two, you can do a cryotherapy. We use liquid nitrogen. Number three, you can inject steroids to discourage fibrosis. And recently, you can perform a poetry. And this is something that we'll talk about another day. Hopefully, I have the time. I had one patient who tried everything, nothing was working. And then we again use the poem technique, create a submucosal bleb, go in underneath the stricture, and we dissect all those fibrous tissue. I just saw her in the office last week, 6 months after. I haven't heard from her. Before that, we're doing dilation every 2 weeks. Yeah, so after that submucosal dissection of the fibers, I have not seen her in 2 weeks. Sorry, in 6 months.
Okay. If in a child, let's say in a child with this same scenario, recurrent stricture, do you inject steroid, and at what age do you think steroid will be safe for the child?
Oh yeah, the child is safe. Steroid is very safe, even in a kid. Yeah, it's very safe. Every time you dilate, you just get your Kenalog or triamcinolone, and you inject it. Yeah, I don't see any contraindication to steroids. It's very safe, especially we don't have much. Especially we don't have another option. If you have a specific case that you want to talk about, we can talk about it later, so I know the specifics of the case.
All right, thank you. So, in using a fully covered stent for a bile, when you deploy fully covered stent in a managing bile, how long do you leave the stent?
So for bile after lap chole, you don't have to use the fully covered stent. You can use the plastic stent. But 6 weeks, 6 to 8 weeks is all you need. The ERCP in stenting is so effective for bile leak that you really don't have to do an ERCP. You can just remove the stent. But sometimes when the stent is in there may be some stones around the stent, so that's why you do the ERCP. And for bile leak, you don't have to cross the leak. If the leak is a duct of Luschka leak, intrahepatic, you don't have to cross it. Just place your stent, 10 French by 7 centimeter stent, and you're good to go. It's very effective for bile leak. And that's one indication where you don't have another option. You gotta do an ERCP. I don't know how the surgeons in Nigeria have been managing without widespread availability to ERCP. I see the question from Kenneth here. Teaching hospitals and centers might be looking to start a program. How should they be thinking about program design? That's a tough one, man, because I think you first have to establish a full interventional endoscopy program and let it run for about 1 to 2 years to make sure all the kinks are ironed out before you start training people. Because if you have somebody with you for 1 year and you're struggling to get resources and equipment, this equipment are not expensive. We just need commitment from one hospital to say, we are going to be the center for interventional endoscopy, and we're going to get all the equipment, and we can start it. We start the program, we'll do 1 2 years, and then we can start to train people, because that's what we need. We need to transfer this knowledge and to people, and those people will go elsewhere and transfer it to people, and before you know it, it will spread out. And this model has been effective. We see it in India. In India, that's how we started. They train a few people. Those people will now go away and train everybody else. Yeah. So that it is possible. We keep the conversation alive. And so can I, hopefully in the future, give me another time, I'll talk about the last few one, which will be bariatric endoscopy, and which will be the bariatric. So while I'll be letting it play while we're letting it, which will be the bariatric endoscopy and treatment of Barrett's esophagus, and some other topics. Thank you very much. It was my privilege to do this presentation.
Yes.
Thank you.
Thank you so much, Dr. Salami. This has been a masterclass, and I know that we've all taken many lessons from this. This has been wonderful, and it just shows us just the potential for what we can do and how much we can offer our patients. Minimally invasive quality care. So there's a lot for us to ponder on and think about how we can advance this across the country as well, because there are many states, many centers that are looking to start these programs. And we know that we will have your support, across the country as people look to start them and they may have questions that you can help them with down the line. This was wonderful. Thank you for giving us this time, and we'll figure out a second session just to complete the rest of the presentation as well. But thank you so much.
Thank you so much, Kenny. And thank you, Dr. Salami, once again for this wonderful session. Thank you, everyone, for attending today's grand rounds. Let's have a good day. Thank you.